Compounding sterile preparations is all about the patient. Whenever I prepared a compound, I ask myself, would I feel confident giving this drug to a member of my own family?
As a healthcare professional, you are responsible for preparing compounded sterile preparations, or CSPs. CSPs are designed to save lives, but if they're incorrectly prepared, they can pose a serious threat to patient safety. This program is based on the United States Pharmacopoeia Chapter 797 and was developed by the American Society of Health System Pharmacists. USP Chapter 797 describes the correct procedures for compounding sterile preparations and sets standards for everyone who mixes CSPs, everywhere CSPs are prepared. As a compounding professional, you are responsible for ensuring the quality of compounded sterile preparations, and the safety of your patients begins with your knowledge of proper compounding procedures. We will watch and learn the most up-to-date information on current preparation guidelines, safety, and science issues. This program is divided into multiple sections corresponding to USP 797 requirements, including the basics of aseptic technique, training requirements, the risk levels of compounding, facility requirements, engineering controls, CSP storage requirements, personnel and environmental monitoring, and quality assurance requirements. Because this program takes a practical, hands-on approach, instructional information will be presented step by step. It's essential you work through the entire program from beginning to end before focusing on those sections most relevant to the work you do. Throughout the program, you'll be asked to pause and refer to your companion guide for more information, self-testing exercises, and supplementary activities. As the largest national organization of health system pharmacists, ASHP is committed to helping pharmacists, pharmacy technicians, and the entire healthcare team care for the patients. To find out more about compounding sterile preparations or for additional information about the ways ASHP is working to improve medication use and enhance patient safety, please visit ashp.org. Please take some time now to review the glossary of terms in the back of the guide. Now let's get started. Compounding sterile preparations isn't for everyone. It takes the kind of person who can follow precise written and verbal directions, calculate mathematical equations, operate specialized equipment, and work confidently in an aseptic setting. The most important part of the compounding process is you. Let's review the responsibilities of compounding personnel. Compounding personnel are responsible for every aspect of CSP production, from measurement and dilution to labeling and dispensing. CSPs must be free of all living microorganisms. Parenteral solutions must be as free as possible of particles, pyrogens, and any bacterial toxins that might cause adverse effects. You must use sterile equipment and supplies properly to ensure the safety of your patients. Proper procedures and aseptic technique greatly reduce the chance of contamination. If you work in a facility that prepares special CSPs, including high-risk preparations, hazardous drugs, radiopharmaceuticals, or allergy extracts, you'll need more training. Compounding CSPs is a demanding part of your job, but your knowledge and training means the medication your patients need is the safest and most effective possible. Before you compound sterile preparations, you'll need to learn everything there is to know. You'll receive training from expert personnel, multimedia sources like this program, or professional sources like the American Society of Health System Pharmacists website, www.ashp.org. Personnel receive appropriate instruction in both the theory and the practice of compounding sterile preparations. Formal training and regular competency tests ensure that all procedures for compounding sterile preparations are always followed correctly. Every facility compounding CSPs must implement a complete range of quality assurance indicators and put into practice initial and ongoing training of personnel, competency evaluation, process validation testing, and other quality assurance measures. Make sure you're familiar with your facility's system of tracking medication. In the event of a product recall, you must be able to track affected medications and quickly retrieve any that were dispensed. As a healthcare professional, one of the most important parts of your job is to make quality assurance everyone's daily routine. Your companion guide lists a number of topics to help you customize policies and procedures for your specific work environment. In this section, you'll learn about laminar airflow principles, the use of the laminar airflow workbenches and isolators, and the techniques required to properly perform sterile compounding procedures. Let's begin with the laminar airflow workbenches. Laminar airflow workbenches use specialized high-efficiency air filters to remove many of the tiny particles normally found in the air. Cleaner air reduces the risk of contamination during compounding. Laminar airflow workbenches send a constant flow of twice-filtered air across the work surface at a precisely controlled rate. The aseptic air flows in layers, also called laminars. These layers of air sweep across the work area, minimizing unwanted entry of unfiltered air. Let's look at the process more closely. First, the laminar airflow workbench draws room air through a pre-filter which removes larger contaminants. Next, to ensure consistent airflow, the pre-filtered air is pressurized and then drawn through a second HEPA, or high-efficiency particulate air filter. The second filter removes 99.9% of particles that are 0.3 micron or larger, and as a result, most airborne microorganisms. It's important to keep the airflow between the HEPA filter and the sterile object unobstructed. Allowing a potentially contaminated object between the HEPA filter and the sterile tops of drug vials, syringe hubs, and needles increases the likelihood of CSP contamination. Any contamination might decrease the effectiveness and the safety of your patient's medicine. When working in a horizontal airflow workbench, nothing should pass behind a sterile object. In a vertical airflow workbench, nothing should pass above a sterile object. This is the principle of first air, which means the first object the airflow encounters. Generally, aseptic manipulations should be performed at least 6 inches inside the workbench to prevent reflected contamination from the worker's body or contamination from particles carried in turbulent air patterns. When placing or moving objects, take care to keep the air vents clear. Even small materials inside the laminar airflow workbench can disturb the pattern of airflow. A poorly placed object's zone of turbulence could even extend outside the workbench, allowing unfiltered room air to leak into the work area. Compounding isolators require a different set of techniques. If you're working in one, refer to the manufacturer's instructions. You will need to follow specific procedures concerning the use of the pass-through and compounding chambers, placement of equipment and supplies, and use of the isolator gloves. If you're still a little unclear on just how laminar airflow technology works, or why your hands should be positioned so that the area of first air is not blocked, take a few minutes now to go back and review the beginning of this section. Now let's take a moment to review the general principles of laminar airflow workbench operation. Aseptic manipulations should always be performed at a point which prevents reflected or backwash contamination. Generally, this is about 6 inches inside the workbench, but that must be confirmed by a test of the individual workbench. A laminar airflow workbench should remain on. If the laminar airflow workbench is turned off between aseptic processing sessions, it must be operated long enough to be free from room air in the critical area for at least 30 minutes. Before use, all interior working surfaces of the laminar airflow workbench must be cleaned and disinfected, top to bottom, back to front, away from the HEPA filter. First with the sterile water, and then with the residue-free disinfecting agent, which is allowed to dry before compounding begins. Sterile 70% isopropyl alcohol is usually used as the disinfecting agent. Nothing should be allowed to come in contact with the HEPA filter. This includes cleaning solution, aspirate from syringes, or glass from ampules, which should never be broken toward the filter. A laminar airflow workbench should be positioned away from excess traffic, doors, air vents, or anything that could produce air currents capable of carrying contaminants from the clean room into the workbench. Only objects essential to preparation should be placed in the laminar airflow workbench. No paper, pens, labels, or trays. Laminar airflow workbenches must be tested every 6 months by qualified personnel. If the workbench is moved or if filter damage is suspected, airflow velocity and HEPA filter integrity must be tested. And finally, remember that without proper aseptic technique, even the use of a laminar airflow workbench cannot ensure preparation sterility. Appropriate behavior in the sterile compounding environment ensures the highest level of safety. And for our purposes, sterile compounding environment includes the buffer area surrounding the laminar airflow workbenches and the ante area. So, what must be avoided in compounding areas? No eating, drinking, gum chewing, or smoking. No hand, wrist, or other visible jewelry, and no visible piercings of any kind. No makeup. Makeup has the potential to shed flakes and particles. No artificial nails or extenders. Your natural nails must be kept trimmed and neat. If any compounding personnel have rashes, sunburn, weeping sores, conjunctivitis, or an active respiratory infection, he or she must be excluded from working in the sterile compounding environment. To minimize airflow turbulence, talking and coughing must be directed away from the work area. For more information about workbenches and to review the materials we've just covered, please refer to your guide. A clean room is designed to minimize or even eliminate bacteria and is the cleanest environment in which to compound sterile preparations. Any opening in a direct path between a CSP and the environment or any surface coming in direct contact with the preparation and the environment is called a critical site. The degree of exposure during compounding is affected by a number of factors, including length of exposure time, size of the critical site exposed, and nature of the critical site. Compounding personnel must pay careful attention to processes, organization, efficiency, and elapsed time to keep exposure to a minimum. Engineering controls reduce the potential for airborne contamination by limiting the amount and size of contaminants in the CSP processing environment. Primary engineering controls include horizontal and vertical airflow workbenches, biological safety cabinets, and isolators. In most cases, facilities use a laminar airflow workbench to provide the environment for critical sites. All of the primary engineering controls are designed to maintain an air quality of ISO 5. The barrier isolator system uses a technology to minimize personnel contact and separate the external environment from the critical site. Compounding aseptic isolators are used for the preparation of non-hazardous CSPs, while compounding aseptic containment isolators are used for hazardous drugs such as chemotherapy. An isolator can be a useful alternative to a traditional laminar airflow workbench in a clean room, but the isolator must be supported with proper operation, maintenance, monitoring, and control procedures. Achieving, then maintaining sterility and a contamination-free environment results from the quality of components, the compounding process used, environmental conditions during the compounding process, and, most importantly, personnel performance. Primary engineering controls are placed inside another environment called the secondary engineering control or buffer area. If the buffer area meets air quality, HEPA filtration, air changes per hour, and room pressure differentiation criteria, it's considered a clean room. Secondary engineering controls also include the ante area, the environment just outside the buffer area. Primary and secondary engineering controls are considered classified space and must be certified by qualified personnel at least every 6 months. One measure they test is air quality. Air quality is classified by the number of particles of a specific size per volume of air. Primary engineering controls must meet the standard of ISO 5. The buffer area must meet ISO 7, which allows more particles but is still very clean air. The ante areas must meet either ISO 7 or ISO 8, depending on the type of connecting buffer area. Bringing an existing facility into compliance might require replacing existing flooring with seamless vinyl, installing HEPA filters, replacing ceiling tiles with plastic-covered cleanroom-grade tiles, and minimizing or eliminating refrigerators, computers, and printers from the compounding area. Sometimes a primary engineering control must be placed in an area that does not meet USP 797 requirements for a clean room. This might happen at a pharmacy that does not have the space or resources to create a clean room, or in a pharmacy satellite to supplement a clean room. In these situations, a primary engineering control may be placed in a dedicated space outside of a clean room called a segregated compounding area. Let's take a quick tour of a typical compounding environment. Here's an example of a clean room or buffer area. Note that the room is free of any extraneous devices or storage. Here's an example of an ante-area. Following USP standards, an actual ante-room is not required when compounding low and medium risk level CSPs. A separate ante-room is required for high risk level compounding. The ante-room provides a clean area for hand washing and completing the final checklist of hair and shoe covers, gowns, gloves, and masks. The ante-room should include a hands-free sink, and compounding personnel must be able to enter the buffer area without the use of their hands. Here's an example of a segregated compounding area. Note that it's in a functionally separate area from other activities and must be in a low traffic area to minimize air turbulence. Maintaining your facility's risk level requirements is an important part of your daily routine. Areas where drugs are stored, including refrigerators and freezers, should be monitored to ensure that temperature, light, moisture, and ventilation remain within manufacturer and USP requirements. All IV solutions, drugs, supplies, and equipment used to compound or administer CSPs should be stored in accordance with the manufacturer and USP requirements. For all risk levels, the policies and procedures you establish must be consistently followed to be effective. Good aseptic technique begins with proper hand hygiene and the correct attire. Protective clothing helps contain particles and microorganisms produced by compounding personnel. Protective clothing includes gowns, masks, gloves, hair and shoe covers. Eye protection is recommended at all times and required when working with irritants or hazardous drugs. Remember, no makeup or jewelry can be worn in the clean room. Artificial nails or extenders cannot be worn in the sterile compounding environment. Natural nails must be kept neat and trimmed. Most CSP contamination results from touch. Proper hand hygiene and garbing procedures minimize risk to your patients. Before entering the buffer or segregated compounding area, compounding personnel must remove personal outer garments, all visible piercings and jewelry, and all cosmetics because they shed flakes and particles. Let's get ready to enter the clean room. First, don dedicated shoes or shoe covers, head and facial hair covers, and a face mask. Next, complete proper hand hygiene. Remove debris from under your fingernails using running warm water and a nail cleaner. Wash your hands and forearms to the elbows with soap and water for at least 30 seconds. Dry your hands and forearms using an electronic hand dryer or lint-free disposable towels. Next, don a non-shedding gown with sleeves that fit snugly around the wrists and neck. Now, just before you enter the buffer area, apply a waterless alcohol-based surgical hand scrub following the manufacturer's recommendations and allow your hands to dry. Finally, don sterile gloves and be sure to examine the gloves for holes. Replace any punctured gloves immediately. Apply the waterless alcohol-based surgical hand scrub to the gloves and allow the gloves to dry. During compounding, you should periodically disinfect your gloves with sterile 70% isopropyl alcohol and allow them to dry thoroughly before continuing. When personnel leave the compounding area during a work shift, the exterior gown may be removed and, if not visibly soiled, hung inside out and reused for that work shift only. Now remember, shoe and hair covers, masks, and gloves cannot be reused. New ones must be applied before re-entering the compounding area. Returning personnel must repeat all hand hygiene before entering the compounding area. You must always use the same garbing and gowning procedures when compounding with isolators, unless the isolator manufacturer can provide written documentation based on validated environmental testing that any components of garb or cleaning are not required. Before you can begin to compound a CSP, check the manufacturer or USP guidelines or appropriate scientific reference to confirm that all ingredients are stable, compatible, and appropriate for the preparation. When compounding CSPs, never use expired, inappropriately stored, or defective products. Confirm that ingredients will result in a final preparation that meets physiological norms of solution osmolality and pH for the route of administration. Make sure you inspect each ingredient and container for defects, expiration date, and product integrity. Promptly remove any suspect product from inventory. In most facilities, the majority of CSPs are non-hazardous preparations. Additional skills are required to prepare high-risk, hazardous drugs, allergy extracts, and radiopharmaceuticals. You can learn a lot by observing other compounding personnel mix sterile preparations. However, you will need training and one-on-one observation to become proficient in aseptic technique. Your supervisor will help you develop this skill. Compounding sterile preparations requires a pristine work area. Compounding personnel must clean and disinfect primary engineering controls. Some facility cleaning may be done by trained housekeeping personnel, but compounding personnel must know how to clean and disinfect every surface of the sterile compounding area. Let's distinguish between cleaning and disinfecting. Cleaning removes visible solids or soiling before disinfecting. After cleaning, disinfecting removes microbial contamination. Primary engineering controls must be cleaned and disinfected. At the beginning of each shift, before each batch, at least every 30 minutes during compounding, and when surfaces are visibly soiled. Also when surface contamination is known or even suspected. To clean an area, remove items, then clean surfaces by removing loose material and any residue from spills. For water-soluble residue, use sterile water to clean the surface. After cleaning, wipe the surface with sterile 70% isopropyl alcohol or a similar residue-free disinfecting agent. Allow time for the disinfecting agent to dry before resuming compounding. Counters and other easy-to-clean surfaces must be cleaned daily. Trash should be removed at least daily or when bins are full. Cleaning should be done carefully with minimal movement so air quality is not compromised. Floors in the buffer area, ante-area, and segregated compounding area must be mopped daily with a cleaning and disinfecting agent, and never during aseptic operations. Mops, wipes, sponges, and other cleaning materials must be non-shedding and dedicated for use only in the sterile compounding area. Cleaning materials cannot be removed from the area except for disposal. Cleaning starts in the cleanest area and then moves outward, so if the same mop is used to clean both the buffer and ante-areas, then the buffer area is mopped first and then the ante-area. Ideally, all cleaning materials are disposable and discarded after one use. Activities which generate particles, including removing of supplies from cardboard boxes, should never be performed in a buffer area, ante-area, or segregated compounding area. These items should be unpacked and placed into plastic bins outside these areas. Wipe all supplies and equipment removed from shipping cartons with a suitable disinfecting agent. Sterile supplies and sealed pouches remain in the pouches until the contents are taken into the primary engineering control. Walls and ceilings must be cleaned monthly. Storage shelving should be cleaned at least monthly, removing every item and cleaning the shelves thoroughly before returning items to their bins. Some facilities use devices such as repeater pumps, automated compounding devices, or robotic devices. Repeater pumps allow repetitive volumes of solutions to be dispensed, such as when compounding a batch of syringes. Automated compounding devices, or ACDs, are designed to streamline the labor-intensive process involved in compounding multi-component formulations, such as total parenteral nutrition, or TPN. The devices automatically deliver individual components in a predetermined sequence. Proper use of ACDs can improve the accuracy and precision of the compounding process. Robotic compounding devices remove much of the potential for touch contamination and are designed to operate under strict conditions. But don't get too comfortable. Personnel must be well trained, and the equipment must be properly calibrated, set up, verified, and maintained for these devices to accurately deliver ingredients. USP 797 defines level of risk by the complexity of preparation, the time a CSP is in storage before administration, engineering controls, facility requirements, and other factors. Consistently employing these definitions of risk protects the patient and compounding personnel. A CSP's risk level begins with the complexity of the compounding process, either low, medium, or high. All risk level preparations must be prepared using proper aseptic technique. but each of the risk levels have different requirements to ensure preparation integrity and patient safety, and each higher risk level builds on the requirements of the previous level. For example, compounded sterile preparations in the medium risk level must meet or exceed all of the quality assurance recommendations for low risk level preparations. The Beyond Use date assigned to a CSP is based on its risk level. Most pharmacies mix both low and medium risk preparations. As you would expect, quality assurance indicators developed for low risk level CSPs are the most easily satisfied. Low risk level CSPs are those made with no more than 3 sterile ingredients, compounded using closed or sealed systems, and using only simple manipulations. So a common example of a low-risk level CSP would be a single bag of 5% dextrose with 30 milliequivalents KCl added, or 1 dose of 1 vial of cefazolin that was reconstituted, then placed in a 50 ml piggyback. A medium risk level CSP also contains only sterile ingredients, but may include more complex aseptic manipulations. These preparations may be used for multiple patients or for one patient on multiple occasions. Common examples of a medium risk level CSP include a batch of 1 gram cefazolin syringes, a liter of fluid containing 3 additives, or a TPM bag containing amino acids, dextrose, and several additives. The preparations with the most potential for contamination are those that start with non-sterile drugs, chemicals, or containers. A high-risk CSP has at least one of the following characteristics. It contains non-sterile ingredients, including manufactured products not intended for sterile routes of administration. It was made using a non-sterile device. Compounding personnel were improperly garbed and gloved, or non-sterile water-containing preparations were stored for more than 6 hours before being sterilized. In addition, if any of the following are exposed to air quality worse than ISO 5 for more than 1 hour, a CSP is considered high risk. Sterile components of commercially manufactured products, CSPs that lack effective antimicrobial preservatives, or sterile surfaces of devices and containers for the preparation, transfer, sterilization, and packaging of CSPs. For example, preparing a highly concentrated morphine solution from morphine powder or preparing an ophthalmic solution containing even 1 non-sterile component are both considered high-risk CSPs. Situations may arise when CSPs must be mixed for immediate patient use, for example, during a cardiac or respiratory arrest. When preparation of the CSP under low-risk conditions would subject the patient to additional risk due to delay, personnel such as nurses may be required to prepare immediate-use CSPs. Immediate-use CSPs are preparations mixed outside of a primary engineering control. Only low-risk preparations can be prepared for immediate use. Medium-risk and high-risk preparations must be mixed under conditions described in USP 797. Immediate-use CSPs are exempt from requirements for low-risk level CSPs only when all of these criteria are met. They involve only simple transfers, contain no more than 3 ingredients including the base solution and any diluent, aseptic technique is followed, administration begins within 1 hour of the start of preparation, and the CSP is properly labeled. See your companion guide for complete information concerning immediate-use CSPs. Let's talk for a moment about Beyond Use dates. The assignment of Beyond Use dates is dependent on 2 conditions: the stability of the drugs in the CSP and the microbial limits of sterility as defined by USP 797. The time limits listed in USP 797 must be followed unless the CSP undergoes a separate, more rigorous sterility test. In general, low-risk agents can be stored longer than medium or high-risk CSPs. In the absence of passing a sterility test, the storage periods for low-risk preparations cannot exceed 48 hours at controlled room temperature, 14 days at cold temperature, or 45 days in a solid frozen state. USP 797 applies until the drug is administered. When administration begins, other references, recommendations, and the pharmacist's professional judgment are required to determine the maximum hang time of a sterile preparation. Only low-risk, non-hazardous CSPs and radiopharmaceuticals for a specific patient can be prepared in a segregated compounding area, and administration of these preparations must begin within 12 hours of preparation. If the manufacturer recommends a shorter time, the shorter time must be used. Low-risk CSPs with the 12-hour or less beyond use time must meet all of the following criteria. The primary engineering control must be certified with a segregated compounding area. The segregated compounding area cannot be in an area that has unsealed windows or doors, that connects to the outside or high traffic areas, or that is adjacent to construction areas, warehouses, or food preparation. Sinks should not be located immediately adjacent to the primary engineering control. Personnel compounding sterile preparations in a segregated compounding area must be appropriately gowned, using the same buffer area or clean room procedures and garb. And all procedures must be followed for cleaning and disinfecting the sterile compounding area, competence documentation, and air sampling. In the absence of passing a sterility test, the storage periods for medium-risk preparations cannot exceed 30 hours at controlled room temperature, 9 days at a cold temperature, or 45 days in a solid frozen state. For high-risk level preparation, in the absence of passing a sterility test, the storage periods cannot exceed 24 hours at controlled room temperature, 3 days at a cold temperature, or 45 days in a solid frozen state. High-risk preparations that are made in batches of more than 25 units must have a sterility test performed for each batch. USP 797 sterility times will be the outside limit of what you use at your facility. Always consider your preparation's individual stability and microbial sterility information. When making a decision between sterility time recommendations for beyond use dates, choose the shortest time period. The storage and stability limits for proprietary vial and bag systems are determined by their manufacturers. These point-of-care activated products are not assessed according to USP 797 risk levels. Refer to the companion guide for further information. Single-dose containers are intended for only one use and include bags, syringes, ampules, and vials of sterile products. Opened ampules must be used immediately. After withdrawing a dose, the remaining content cannot be stored. For other single-dose containers, USP 797 makes a distinction between containers opened within a primary engineering control and those opened outside a PEC. For example, on a patient care or procedural unit, if opened within a primary engineering control, opened bags, bottles, syringes, or vials can be used within 6 hours, as long as they remain within that environment and a shorter time is not mandated by the manufacturer. However, if these containers are opened in an air quality worse than ISO 5, they must be used within 1 hour. Multiple dose vials are designed for longer-term use. Unless otherwise specified by the manufacturer, the maximum beyond use date after initial entry is 28 days. Let's talk for a moment about labeling. All risk-level CSP labels should contain, at minimum, the following information: all solution, drug and ingredient names, amounts, strengths and concentrations, and the total volume of CSP, beyond use date and time, appropriate auxiliary labeling, any storage requirements if the CSP will not be immediately administered, device-specific instruction if applicable, and identification of the individual responsible for checking the CSP. This may be indicated by an internal lot number if the batch record documentation includes the approving pharmacist. For patient-specific preparations also include the patient's name and other patient identification, the prescribed administration regimen. Labels on prescriptions dispensed to ambulatory patients require a prescription number and all additional information mandated by federal and state laws and regulations. Special CSPs, including parenteral nutrition solutions, epidural preparations, allergen extracts, and radiopharmaceuticals, require additional labeling. You've just finished mixing a CSP for Mrs. Pollard's son, Hal. You promised it would be ready before noon, but it was a busy morning. It's already 11:30, and you know your patient relies on his medication. Can you release this preparation? not before a final safety check. To ensure accurate compounding, USP 797 requires a final check of the CSP, including the order, label, and preparation. A double check by another qualified person is best practice and provides an additional layer of safety. For CSPs mixed in a pharmacy, a pharmacist will provide the final check. To meet USP 797 requirements, all CSPs should be physically inspected for preparation integrity. This includes a visual examination for container enclosure integrity and a check for particulate matter using a black and white background. If particulate matter is observed, the preparation should not be used. Someone other than the compounder should verify the proper measurement, reconstitution, and component usage and include a review of the order, label, and preparation. This provides an independent double check, a key safety step. Low and medium risk level CSPs that exceed USP 797 beyond use dates require additional testing. High risk level CSPs made in groups of more than 25 must be tested for sterility. If high risk level CSPs must be dispensed prior to obtaining results of their sterility tests, USP 797 requires daily observation of the incubating test specimens and a process to immediately recall any potentially contaminated preparations. It's the responsibility of the pharmacy and pharmacy personnel to ensure CSP quality and integrity is maintained during transit within or outside the healthcare system. Pharmacies that mix CSPs only for inpatients and related ambulatory patients should establish policies and practices that support safe storage and transport within the system. Pharmacies that compound preparations for home care or patients at other facilities must consider a few additional steps. Properly packing and shipping CSPs is a big part of maintaining a safe and consistent preparation. A reliable courier service or alternate method of delivery must be used to ensure the preparation is delivered in its proper condition. Each pharmacy is responsible for establishing, maintaining, and assuring compliance through written policies and procedures. Where non-pharmacy personnel are assigned tasks involving any of these responsibilities, the policies and procedures should be developed by the pharmacy and be part of the ongoing training program for all personnel. USP 797 provides specific guidelines and recommendations dealing with quality control of CSPs after they leave the pharmacy, including packaging, handling, and transporting, use and storage, readying for administration, dispensing of returned CSPs, education and training, packing CSPs for transit, and storage in locations outside compounding facilities. All of these areas provide specific guidelines to maintain the sterility and stability of CSPs until they are delivered for administration. Compounding personnel must understand that compounding processes and those who perform them have a significant impact on the quality of the preparation. Touch is the principal source of CSP contamination. Controls ensure CSP sterility and accuracy. Quality cannot be inspected into the final preparation. It must be built into the CSP preparation process and appropriate quality controls. Together, training and testing ensure the high quality and safety of a CSP program. Staff are evaluated by formal written examination, practical return demonstration of aseptic technique, validation testing using growth media fills, gloved fingertip testing, surface sampling, and finally other tests outlined in USP 797. Each healthcare setting requires a specific written employee training and evaluation program. A comprehensive training program ensures compounding personnel are skilled and knowledgeable. Personnel assigned to the preparation of CSPs must successfully complete specialized training in aseptic technique and aseptic area practices. Your program will provide training in the necessary skills to perform component identification, equipment utilization, and aseptic technique. Personnel who compound CSPs must pass written tests of basic and compounding knowledge, appropriately garb and perform hand hygiene, clean the compounding areas, perform aseptic technique for every type of preparation compounded in the facility, properly use equipment, successfully complete a media fill test, demonstrate that gloved fingertips are not contaminated, demonstrate that surfaces are clean using surface sampling techniques, and complete the requirements detailed in your facility's quality assurance plan. USP 797 provides sample competence documents that can be tailored for use by any compounding site. A media fill test must be successfully completed prior to mixing CSPs and then again at least annually. A successful media fill test demonstrates the ability to aseptically compound sterile preparations. Using a component that supports bacterial and/or fungal growth, a media fill test mimics preparation of a CSP. A successful test shows no growth after incubation. If high-risk CSPs are mixed in a facility, the media fill test must be done twice a year. The media fill test used should closely mimic the characteristics of the risk-level CSPs being compounded. They should be scheduled under the same challenging or stressful conditions encountered in the work area, and usually at the end of the day. A gloved fingertip test is done after garbing, but before applying alcohol to gloves. It demonstrates the ability to aseptically gown and glove. Touching an agar plate with the fingertips and thumb of a gloved hand tests proper aseptic technique. The plate is a growth medium for any biological contaminants, which could, if this weren't a test, contaminate a CSP. A successful test shows no growth after an incubation period. Initially, the gloved fingertip test must be successfully completed 3 times, and then once a year. If high-risk preparations are compounded, the test must be done at least twice a year. Surface sampling checks the cleanliness of compounding surfaces. This must be done periodically to ensure that the proper procedures and the appropriate cleaning and disinfecting solutions for your facility are being used. Competence is essential to ensuring safety in this specialized area of practice. Well-trained personnel will recognize when things aren't going as planned. If something doesn't seem right, bring it to the attention of your supervisor and ensure the CSP is not dispensed without further checking. Let's take a look at environmental monitoring for a moment. Environmental monitoring ensures your primary and secondary environmental controls work properly and the compounding facility is clean. Equipment and areas requiring environmental monitoring include primary engineering controls, including laminar airflow workbenches, biological safety cabinets, compounding aseptic isolators, and compounding aseptic containment isolators. Secondary engineering controls such as the buffer area and anti-area, and segregated compounding areas. Some daily monitoring is required. For example, controlled temperature areas must be monitored at least once daily, and the results recorded in a log. The temperature of drug storage areas must meet the following USP requirements. Controlled room temperature is between 20 degrees and 25 degrees centigrade. Controlled cold temperature is between 2 and 8 degrees. Freezing temperature is between minus 25 and minus 10 degrees. Continuous temperature monitoring can be substituted for manual checks, provided it's calibrated according to the manufacturer's recommendations, complies with federal and state requirements, and compounding personnel verify daily the recording device is functioning properly. A comprehensive plan includes more extensive monitoring and must be performed every 6 months and under situations including before using new facilities or equipment, after servicing of facilities or equipment, in response to identify problems with preparations or staff technique, in response to issues with CSPs, observed work practices, or patient-related infections if the CSP is a potential source of infection. 2 types of environmental monitoring are required by USP 797, non-viable and viable. Non-viable environmental monitoring includes testing to ensure particles in the air do not exceed established limits, monitoring pressure or velocity differences between the buffer area, anti-area, and non-classified space, confirming temperature and humidity are within guidelines. Monitoring is performed by compounding personnel. Validation of monitoring is confirmed by a qualified certifier every 6 months. To ensure ISO standards are being met, the certifier will measure air changes per hour and the number of particles in the environmental controls. Particle levels must be checked in the primary engineering control, in the buffer area, and in the anti-area. These areas must not exceed particle limits of their ISO class. A pressure gauge measures the differential between the buffer area and anti-area, and the anti-area and the general area. The pressure of an ISO 7 area used for preparation of non-hazardous drugs must be at least 0.02 inches higher than the anti-area, and the anti-area must be at least 0.02 inches higher than the general area. The pressure of an ISO 7 area used for the preparation of hazardous drugs must be at least 0.01 inches lower than the anti-area. In facilities where the buffer and anti-areas are in the same room, a velocity meter ensures a minimum differential airflow of 0.2 meters per second between the buffer area and anti-areas. The pressure or velocity measures must be reviewed and recorded in a log at least every work shift by compounding personnel or by a continuous recording device. A certifier will check the pressure or velocity readings every 6 months to confirm the daily readings are valid. Viable environmental monitoring detects microbial or fungal contaminants in the compounding area. While particles themselves are a risk to CSPs, they may be carrying smaller, even more dangerous microbial or fungal contaminants. An environmental sampling plan should be developed based on the compounding activities performed, locations to be monitored, the device used to monitor, the frequency of collection, and corrective procedures if readings exceed thresholds. All areas at risk of contamination must be monitored. These include inside the primary engineering controls, counters, areas near doorways, and any pass-through. Use plates or swabs containing growth media to detect bacteria. If high-risk preparations are compounded, the media must also detect fungi. Media used for sampling must include additives that counteract the effects of disinfectants. Viable air sampling must be done using a volumetric collection method. A device such as an electronic air sampler pulls a specific volume of air through the device and onto a culture plate. If microbial or fungal material is present, it will show up after incubation as a colony-forming unit, or CFU. Counts of CFUs must be evaluated for adverse trends and documented and monitored as CFUs per cubic meter of air. As part of recertification, viable air sampling must be performed for facilities and primary engineering controls at least every 6 months. For additional required procedures, please refer to the Controlled Environmental Testing Association Certification Guide for Sterile Compounding Facilities. As you know, a critical factor in ensuring the safety and well-being of patients is training. This applies not only to pharmacy personnel, but to everyone who handles or uses CSPs. For patients who receive home infusions, it's essential that the patient or patient's nurse, caregiver, or spouse clearly understand how to store, administer, and dispose of the CSP. All facilities must provide a formal program to ensure every individual involved in the handling and use of CSPs is knowledgeable and properly trained. Upon completion of this training program, the patient or caregiver should be able to describe the therapy involved, including the condition for which the CSPs are prescribed, be able to identify and report anticipated or adverse effects, inspect all drugs and devices to ensure proper temperature were maintained and that the solutions have no evidence of deterioration, handle, store, and monitor all drug preparations and supplies, visually inspect preparations, including checking labels to ensure suitability for use, clean the in-home prep area, wash hands, use proper aseptic technique, and be able to manipulate all solutions, supplies, and devices, care for catheters, change dressings, and maintain site patency, monitor for any complications and respond appropriately, know when to seek emergency services or professional advice, and properly handle and dispose of any waste preparations. It's not enough to train patients and caregivers. It's just as important to follow up and provide support to ensure patients and caregivers continue to administer and handle CSPs correctly. A key component in the pharmaceutical care delivery model is monitoring a patient's response to therapy. Your facility makes certain that patients are clinically monitored when receiving CSPs. Review and evaluation of adverse event reports can serve as a useful quality indicator and improve care. Your facility should develop an effective feedback mechanism for patients and caregivers to report any concerns regarding CSPs or administration devices. Quality Assurance Plan provides a framework for monitoring activities, evaluation, corrective actions, and performance improvements of your program. For all risk-level CSPs, quality assurance recommendations begin with the establishment of appropriate policies and procedures for compounding sterile preparations. These policies must be in writing and made available to all compounding personnel. Review quality assurance recommendations at least annually to reflect current standards of practice. Established quality assurance policies and procedures, supported by comprehensive training at regular intervals, must be a part of everyone's daily routine. All personnel who mix CSPs must have documentation of competence. Training mandated by USP 797, as well as your state and internal hospital policies, must be documented for each individual who compounds sterile preparations. A quality assurance plan also covers facility monitoring procedures, including certification of primary engineering controls and other compounding environments, cleaning the compounding areas, refrigerator, freezer, warmer temperatures, and other monitoring parameters as required, personnel monitoring, including media fill test and surface sampling results, non-viable environmental monitoring, such as the reports of the certification of primary and secondary engineering controls, and viable environmental monitoring, such as reports of electronic air sampling. Providers of CSPs must have a formal quality assurance program to provide a mechanism for monitoring, evaluating, correcting, and approving the activities and processes discussed throughout the program. If any results are outside the limits set in your plan, you must correct the problem and document your actions. Your facility should have a formal reporting and remediation plan in place. Quality assurance consists of written proof of the following: compounding personnel are trained, CSPs are prepared using the correct components and correct ratios and volumes, descriptions of specific monitoring and evaluation activities, specific procedures for reporting and evaluating results, and a record of personnel responsible for each aspect of the quality assurance program. When action limits or thresholds are exceeded, your facility's quality assurance program must ensure any plan aimed at correcting problems includes appropriate follow-up mechanisms, corrective actions, and documentation. Your companion guide lists a number of topics you may want to include as you customize policies and procedures for your working environment. We hope you've enjoyed ASHP's Visual Guide to USP Chapter 797. Before we end the program, please consider a few final points. The most important goal of quality assurance for compounded sterile preparations is the safety of your patients. Your diligence and professionalism when compounding CSPs is the best way to minimize contamination and inaccuracies. While high-risk level compounding has more stringent requirements, all levels require special procedures. Your facility should always be in full compliance with the appropriate quality assurance indicators. Always report any concerns to your supervisor. And finally, applying good aseptic technique fulfills your commitment to quality in preparations, service, and professional integrity. Remember, compounding sterile preparations is about patient safety. We hope this training program has given you a better insight into the 797 practice standards to help ensure that your patients receive the best care possible. Thank you so much for your time and attention.